Good evening, everyone. Kathy, can you hear me?
Yes, I can.
So good evening, everyone. Or I probably shouldn't say good evening because some of you are on a different time zone and it's still afternoon for you, but it's evening for Kathy and I and the rest of us here on the East Coast. Welcome again to the third in our first series of COVID-19 webinars. And tonight we have our own Kathy Bishop who's going to be presenting. And so I'll let Kathy, whoops, why do I have my webcam on? I do not want my webcam on. Not camera ready.
I'm not either.
I pressed something by accident, I guess. Anyway, tonight's our own Kathy Bishop, who's going to be talking about social distancing, and I'll let her introduce herself in just a minute. The usual housekeeping notes, the materials, if you go over to the right-hand side of your screen and click on that little box next to materials, you'll see there are 3 things there that Kathy sent to be uploaded. One is the PowerPoint slides and then 2 additional pieces of material. They'll also be sent out following the webinar along with the recording. If you have a question at any point, don't feel you need to hold it till we have a formal Q&A session. Go ahead and type it in the chat box there, and when their timing is right, we will, we'll ask those questions. So just go ahead and do it anytime. You don't need to wait. I see a few people, or did see a few people, who look like maybe they didn't have their audio enabled. And so if you go to the right-hand side of your screen, there's a little box there that says audio. Click on that. Sometimes it's because you're calling in on the phone. And the other reason sometimes people can't hear is because you have not, turned on the audio on your computer, or you have it muted, or it's not turned up enough. So that's the other reason sometimes people will say they can't hear. And don't forget, we have the 4th in our series coming up next week. Is it next week or the week after, Kathy? I guess it's the week no, it is next week.
No, it is next week. We're in May already.
Yeah,
next
time flies when we're having fun.
Yes.
And so that will be our 4th, but I think there are some others in the works, and stay tuned for more information about that. So with that, Kathy, I'm just going to go ahead and turn it over to you and mute myself and take it away.
Sure. You're going to monitor for any of the questions that come through the chat?
I will. Do you want them when you get to a good point to
Sure.
draw a breath, and I'll ask them then? Okay.
Makes it easier
Sounds
if it's
good.
relevant to what I'm talking about. So whenever.
Okay. Sounds good. I'll do it.
Great. Good evening, everyone. And again, we really value that you're here with us for the next hour and a half. Most of you are with our NTG affiliated regional trainers. A few of you are not, so I will do a little better job of introducing myself and the NTG this week. First of all, the National Task Group on ID and Dementia Practices has been about 10 years now, and one of the most important things you need to know about is that we are a total volunteer organization. The National Task Group, all the presenters that have presented so far I'm an NTG member as well tonight, and Kathy's service next week. Also, we're volunteering our time because this is such an important effort. Related to that, finally have permission to talk about the donation. Originally had hoped to be able to donate 100% or 90%. Really, we'll have to donate 80% of those of you who paid the $20 for this series. Because like everyone else, things have been canceled, and our revenues are mainly our 3-day trainings that we do, a few small grants as well. Most things have been put on hold, like all of our lives. So to be able to keep us thriving throughout and be able to keep doing this, we will be keeping 20%. 80% will be donated to the ARC of the US, their COVID-19 relief fund. We are thrilled to be able to do that. When Catherine sends out the handouts, I will also give her their sheet for that and the link if any of you would like to donate separately. But know that 80% of this, the funds from this, will be donated to the ARC, and we are thrilled to be able to help out in this difficult time. So thank you for that. I am the co-chair of the NTG Education and Training Committee, along with Catherine Peers. Most of you that are on, we have met over the years, and so pleased that you're with us tonight, and so pleased that we've had the opportunity to meet you over time and to be able to help you do the very important work that you do. I actually began work as a preschool teacher. That was my special ed teacher. Became an ICF program manager, and then was hired into staff development and training in a very large New York State organization, where the director asked me if I would monitor a program on aging to see what was needed for the very large, at that point was an old state school. It was the old Rome State School, which was one of the largest in the country, became the CNY DDSO for 8 counties over the years. I fell in love with this topic and went back to school for a PhD. My particular area that I fell in love with was the environment, sensory processing, and ways to modify the physical environment. And tonight, that's what I'm going to focus on and talk about. I'm not naive or idealistic enough to think that social distancing is something that is really possible in many of our work settings, residential settings, or within families and groups. However, I'm hoping to give you a different perspective by talking about sensory processing, sensory issues, and trying to help you understand what the world looks like for people with ID and dementia. And I'm hoping with a few other suggestions that I'll be able to give you some practical work, some practical ideas to help make a difference. I'm probably more stressed about this topic than any other I've ever presented, because I really hope to add a little something in a topic that's difficult and is challenging, because social distancing is such an issue. Just wanted to add a little levity to tonight. Like many of you, we have been socially isolating, not quite quarantining, but close. We have traveled back from our Florida home to our New York State, upstate New York home, which was a challenging trip to say the least. We have 3 pets. We have the two Maine Coon cats. I'd love to say these are ours. They're very close to looking like our 2 Maine Coon cats. However, this is a stock photo that was so similar that I took it. From our cats to your house during our isolation, with plenty of time to think, we've done the math. We can't afford the dog. In our case, the dog is a Shar-Pei. The 3 of them are an unbelievable team. But every time I see that, which actually we can't afford the dog, is something that we have on a coaster in one of our cars. And every time I look at it, I laugh. And so I thought that it would be good in this time that is so stressful for all of us, that we're all going through such trauma, grieving, sense of loss, that I thought it would be great to maybe start out with something to chuckle about. And certainly the pets around the world have benefited from their caregivers being home, or their parents being home, their family being home. Caregivers are essential to our healing, and I do think I hear that there's at least one person that is unmuted. If you could unmute yourself, please. Caregivers are essential to our healing, and one person's visitor is another's critical caregiver. We will inevitably learn much from our national experience with COVID-19. I hope one of the enduring lessons will be a heightened understanding of the critical role that caregivers provide for people living with Alzheimer's. And that's a reporter writing an article. Phil Kudis, Being Patient, is the contributor and the author of this. My addition to that quote is, and the heightened awareness of the importance of the physical environment to influence function and behavior. We can reimagine the environment during this crisis, and I'm hoping you will think of ways to reimagine how our environments can look in the future, that there can be a little something positive coming out of this very, very difficult time for all of us. So let's talk about social distancing. What is it and why? Social distancing, by the way, for many people with cognitive challenges, whether it's a lifelong intellectual disability or it is a later in life Alzheimer's dementia or related type of dementia, social distancing can feel like and look like social isolation. It is something that is, for most people, not natural. Most older adults, especially those with cognitive challenges due to disease or lifelong disability, may not understand the social isolation or what is being expected of them. Notice that most of the challenges in dealing with patients and loved ones with Alzheimer's lies in the disruption of routines. For example, the closures of facilities that would normally allow social interaction. We're going to talk about the importance of habits and routines and how we need to think about ways we can replace the previous habits and routines. There also may be caregivers who used to rely, for example, on adult daycares. So instead of being able to have their loved ones participate in adult daycare, they have to do activities at home. And at a time when we're all stressed, everything turned upside down. The Alzheimer's Association says to keep the flow of information simple and not overwhelming. And so we'll continue to look at these as suggestions throughout. Throughout this, I have where the resources have come from. So you can see, and you have these slides in your materials, so you'll be able to. If anyone, by the way, not just during this presentation, but after, has any questions on this, please don't hesitate to ask. There are more than 6 million Americans who have been diagnosed as having intellectual disabilities. Many of, as you all know, with IDD rely daily on the assistance of others for basic needs to be met. Social distancing may not just be inconvenient or lonely, but could actually eliminate their sources of basic care like food, transportation, assistance with hygiene, or critical emotional support. And agencies as well, even though they're organizations with a number of caregivers who are direct support, are experiencing also the difficulties with social distancing and losing staff who may not be able to come to work because they've been exposed or have tested positive for coronavirus. Years ago, when I was an ICF program manager, I had a gentleman who had been transferred from downstate to upstate through no choice of his own. It was what New York State called repatriation. And this gentleman, at least once a day when I was working, would come to me and look very closely in my face, and he would ask, "What has happened to my life?" And I never really had a good answer for him except to say, "You're here with us now." This is when I'm sure if many people could verbalize this, and in fact, I'm sure each of us every day when we wake up and realize that everything still continues to be in turmoil, we don't have answers for when this will end, and we're in fear for ourselves and our loved ones and the people that we help support. And so I'm sure many of us are asking, what has happened to my life? COVID-19 has disrupted routines and habits, which we'll talk about the importance of, increased fear and confusion. And so if you're seeing increased inappropriate behaviors, the behaviors that may be, and I use quotation marks around the inappropriate because given the context may not be inappropriate at all, but certainly has increased anxiety, has increased everything has changed. And the confusion, especially for people with dementia, it just has to be overwhelming. It's likely changed caregivers, or certainly changed the rhythm of the day of who is caregiving. There could even be with people having to wear protective equipment and clothing. May change in clothing of caregivers. The caregivers may not even look alike, even if they were the same people that they were 2 months ago. And remember, for many of us, as much as 6 weeks ago, life wasn't this way, and maybe even a month ago for some people. And so everything has turned upside down for people with dementia and their caregivers. The location of activities, the rhythm of the day and the week. Time has changed meaning, especially for people with dementia who rely on the routines to function. No one with dementia, no one at all wants to feel not capable, wants to admit they can't do things they've done before. It wants to admit they're confused, and often what will happen will be some way to try to hide that. But when the time has changed meaning and there is no routine to rely on, it can make it difficult for anyone to function. And I'm sure each one of you listening tonight, your lives have changed. And think about how I often get up in the morning in Florida, especially, we had a routine that helped make it the time more meaningful and the days purposeful. But now after traveling from Florida to here, now in New York, I'm waking up in the morning and I don't have a routine established, and everything has changed again. Without the supports I used to have to be able to go out into the community and become attached to the community again, because of course we're still in social isolation here. This is what life is like for all of us, and for people with dementia who can't cognitively understand the fear and the confusion, the anxiety, the fear of safety has to be so extreme that it actually would be amazing if we're not seeing increased difficulties in functioning, increased behaviors that may get in the way of the quality of the life for the person or quality of life for others around. There's a lack of stimulation or overstimulation, inability to connect with those still remembered or important. Let's think about why we have habits, and are there some habits that may now be perceived differently? Let's look. Here is a habits loop. Habits are encoded in the structures of our brain. The longer we've had the habits, the more encoded they are. And especially for people with Alzheimer's disease, remember the loss is first short-term and then over time long-term. If these are long-term habits and routines, even more difficult in the disease of Alzheimer's disease to be able to not have those habits, those routines available. They save us an amazing amount of effort, and many of you may find yourself fatigued at the end of the day because things that you just did and took for granted have to be thought out. For example, in New York State, as in some areas of the other areas of the country, now to be out in public, you need to have a mask on. And so even to go to the drive-through windows, which we do for, unfortunately, our Starbucks up here are closed, which is another loss since coming from Florida. And so today we went to Dunkin' Donuts to have at least one day out into the world. And we're driving in the car that we put away for the winter, just got out and had to go back to the house because we had left the mask that we have in the other cars there and needed to put some masks in this car. We have to relearn everything we're doing. And think about this when even the basic functions are challenging for a person. And so there is a cue, something that cues in the environment, cues the brain that it's time for a particular routine, and the working through the routine and a reward for that routine. When there is no routine to go to, it's a total disruption in this cycle behaviors will change, functioning will change, everything will become more challenging and more confusing. And by the way, for people who have not been diagnosed with dementia, but who may have a high risk, such as people with Down syndrome, there's a really strong likelihood during this time that anxiety and confusion might be mistaken for Alzheimer's disease. And so please be very, very careful that the symptoms of all that we're going through with the stress and the change in routine and the having to relearn everything we do not be thought of as part of the aging process or part of having a type of dementia, but simply be the trauma and stress and the changes that are going on in all of our environments. Routines are essential for functioning. Humans should not have to, and the brain is not set up to think about every single function, movement, activity, everything that happens around. In fact, the brain normally filters out sensory information that is not needed for the moment. But when the routines are so disrupted as they are, the brain, especially a brain that has disease process, which is what a type of dementia is, may not be able to do that filtering anymore. And so there is no long-term memory to go back to and resort to. And it's trying to relearn at a time of your life with a disease process that you can't relearn. For survival in congregate settings or unfamiliar surroundings, and remember, for some people as they go to middle or later stages of Alzheimer's disease, every setting can be unfamiliar. After sleeping a couple hours and waking up, even the bedroom or the living room may now be unfamiliar. Staff may be unfamiliar because of the disease itself. And now we add on what's happening with COVID-19. There's the habit loop, which we saw a minute ago, the cue or trigger. The brain usually goes into an automatic mode. And as a result of that automatic mode, that ability of the brain to filter out, then the behavior, the reaction to that cue occurs. It becomes routine as part of ongoing behavior, but when the whole routine has been challenged and turned upside down, now there has to be a new routine to help the person with dementia function. And I have a checklist that I've actually put together very quickly. The formatting is not great, but it's one of the materials I have for you. I'd love feedback from any of you if it's helpful and if you'd like me to do more work on it. I wanted to have something for you today. And I'll show that at the end of the talk today. Adults with autism and adults with Down syndrome are likely affected by change in routines even more so than others, because so many people rely on routine, especially if they're having sensory processing problems. And the routine is even more important, and we'll talk about that in details in a few minutes. How are habits rewarded? Think about your own habits. Think about what has changed. What was the reward? What are you now trying to put into your routine you didn't have before? And in fact, you may look at the sheet that I've attached for the materials tonight, and you may want to fill it out for yourself to help you figure out routines that you need to substitute, that you need to put in that can help make your days less stressful as well. Habits and routines allow us to function without thinking of every movement and activity. Habits, for example, labeled as obsessive compulsive, non-compliant, tactile defensive, may now be encouraged. For example, people who have wanted to change their clothes 3 and 4 and 5 times a day. Well, that may have been discouraged before, but now with COVID-19 and the possibility that there's been a touching of a surface that might have COVID-19, we're encouraging people to change their clothing or to put on protective clothing. Washing hands. I know people who have felt that they've had to wash their hands 6 and 7 and 8 times during the day, and maybe 8 times in the evening and 8 times in the morning, which used to be behavior considered obsessive compulsive. But now that behavior is expected behavior, needed behavior for safety. And now we're telling people, especially with dementia, after a lifetime of saying you don't need to wash your hands every 15 minutes. Now we're saying, yeah, maybe you do need to wash your hands every 15 minutes. So think about it. It's the opposite. Greetings and salutations may now be frightening. Before we might say hello. I found this in our community in Florida. We would take the dog every morning for about a mile walk around the lake. And as we'd greet, socially distancing, at least 6 feet, but greet our neighbors, instead of saying, good morning, we would say, are you okay? How are you? A whole different greeting. And now I find myself, and I'm sure many of you do, instead of saying take care or till we see you again or it was great talking with you, now we say stay safe and stay healthy. 2 months ago, I would have never ever thought to say those words, and yet I don't think there's an exchange I have these days with anyone, including people when we go to the drive-in at Starbucks or Dunkin' Donuts. That we don't say stay safe and stay healthy. But how frightening to someone with dementia is, why are the people around me saying stay safe and stay healthy? If they don't understand COVID-19, everything's been turned upside down, and now we're using different language, different words. ADLs including eating, dressing, bathing, hygiene, all which are essential for health. The location, who assists, maybe the materials, if you're having trouble getting soap, having trouble getting toilet paper, all of the things that we have used, the objects may have changed because of COVID-19. And so how do we try to make sure, and I'll have a few pictorial examples in a few minutes of things that may have changed. Habits are also usually part of long-term memory, used most often in middle and later stages for people with ADR to be able to function. And yet here we've had this total reversal of what the habits are. If for 20 years you've been getting up at 6:30 in the morning and you've been going off to a program, now you may have had a program change, but that's still basically your rhythm. And you may have moved from one building to another, but been with the same people for 20 years. Now that no longer is happening. You're not seeing those people that you were with for years and years, your peers or caregivers. What happens when you get up and there's no bus to come for you? There's no van to come. Now, instead of getting up and getting dressed to go to program and getting together the materials, maybe the purse you took, now that's not happening. People are staying together in the same place. And the more we can help reinforce that people are safe and figure out the habits people had previously and what we can substitute as routines to help people develop new habits during this time. And I also want you to start, remember, I'm in New York. New York, our governor has been very vocal. One of the things I really appreciate is that he has been talking about that we need to reimagine New York. We need to reimagine that as a result of this, that maybe there's some things that can come out of this that we can make better. And I'm hoping that's what you can think about, that there may be things that we can do, new habits that might actually be better habits, new routines, new ways to structure the physical environment that may help people. And I'm going to talk in a few minutes that I really would like us, instead of to talk about social distancing, because it's so difficult in our services and residences, in our support, that we think about ways to give people territory and personal space, which is something that's always been challenging in large groups, to think about how that may be something that can stay afterwards as we try to redesign to make the environments support people, especially people with dementia who cognitively cannot understand what's going on, but that we can use cues in the physical environment to help support people and to give more personal space so that it doesn't feel as though we're just isolating people, that we're giving personal space and we're trying to calm down the overstimulation that people often have, especially during times of crisis. And we need to recognize for ourselves and for everyone around us, we're all grieving. We're grieving our formal lives, our contact, ability to touch each other or be together. I can't, how many times my husband has reached out or I've reached out for him and then I pull back because I'm really, should we be touching each other? And those of you who know me know that I'm a hugger. And here suddenly we have a time when touching each other could cause an illness, could cause death. And then we need to start thinking about how does this affect for a lifetime, and especially how does it affect people that we support with dementia and IDD. People with dementia are feeling this all around them, but can't understand. Catherine, I'm seeing some comments come through. Is that something you wanted me to stop, or I'm just seeing some flashing?
Sorry, I had to unmute myself. Do you want to do it now?
Sure, go ahead.
Okay, there's just a couple.
Sure.
From Frank Schweiger, and those with tactile sensitivity may not have access to preferred products. Good point.
Yes, great.
And Kara Arcuri says, I'm still providing dance movement therapy on the same schedule as I always have. I'm just doing it remotely. The individuals I work with seem to benefit from having this consistency. After each session, they ask about therapy for the next week.
Perfect. That's exactly part of the suggestions I have towards the end. Great, thank you. That's it?
Yep, that's it for now.
Not a problem. The benefits of routines for people, especially with dementia, maintaining function, practicing an activity regularly, whether it's a physical or mental task, may increase the likelihood of that ability remaining. And so doing things virtually, if there are clinicians in your organizations who are trying to figure out how to support direct support, and people that are now staying in their residence care, exactly what we need to be doing is virtually as much as possible. And if we can have it at the same time, around the same time, and do it on a regular basis. And the other is not everything has to be group activities. It may be a time that there's that just virtual FaceTime and interaction, one person at a time with a particular skill or activity, or interaction with one of their favorite staff from day program. And so there's ways that virtually we can help substitute to be able to make sure that there are some routines and habits for people. Having a routine reduces anxiety. And that's why I know I'm in a very high anxiety mode. The person with dementia may feel more comfortable and confident if he or she knows what to expect. Decreases caregiver stress. Routines can lessen the stress for those caring for people with dementia by making the day more organized and possibly decreasing the chance of challenging behaviors. So one of the things, one of the attachments that I have, in fact, a couple of attachments, it might be the clinicians are working with direct support and helping fill out those to give ideas of how to substitute routines, how to substitute habits, how to restructure the physical environment to make it less anxiety producing in the residences. I know I had one of my colleagues a few weeks ago say how they were using some of their gyms and day program areas for a couple of people to be able to come or to be able to give some relief from the stress that is occurring at the residences, but to do it in a way where people can be socially distanced but still have activities and routines. Especially with dementia, Routine allows for some independence, some ability for people to be able to still perform a function without all direct support. Daily folding the laundry can increase self-esteem and confidence because the person can perform it independently. This is especially in earlier stages of dementia, when people are more likely to be aware of cognitive deficits. Independence in a task can be an encouragement to them. To look at what were the daily routines, what were the daily tasks at the day program site, and how can we support those if they were valuable to the person within the residence, within the areas they're in. How have common objects used every day changed? Do they look different? Is there a pet that was at the day program that's not in the house, or vice versa? Different objects that are used. What has changed? Think about the objects that people use. Are they different than the objects that were being used at the day program? And is there a way they can be replicated to look alike? Think about what you're using, what support you're using, and the objects in the environment. Habits shape your life more than you realize. They're very strong. Our brains cling to them at the exclusion of all else, including common sense. For example, if you've driven the same way to work at the same time every day, for those of you who now are at home and not able to go to work, if you have a chance to go out and maybe do curbside pickup, you may find your car almost automatically turning, or you may be walking in the direction you would ordinarily go to work, because your brain is desperately looking for that routine to not have to think out every single moment of your life. About 40% ordinarily of the actions you perform each day aren't actual decisions, but habits. Watching TV, smoking a cigarette, eating chocolate, biting your nails. Now, these aren't all considered positive habits for health, but they may have been habits that you've had throughout a lifetime that may now be very difficult given COVID-19. And there actually is a pleasure chemicals that are released in the brain. One of the things that has changed for people, the meaning of time. We often tell time by our activity of the moment, where the sun is in the sky or what is happening around us. When we no longer have that, or we change the location where we are, this can make time have no meaning. For those of us who have been home, I know there's some of us on the call that yesterday was the 48th day my husband and I have been socially isolated, not quite quarantined, but close to quarantine. Certainly socially isolated, with only deliveries or going out once a day to go to the drive-through Starbucks, where everyone wore masks, and it was only through the drive-through that you could get it. There was nothing else regular in the day in the past 48 days compared to what my days had been before, and certainly what the schedule on my calendar was really supposed to be. Time locates us in the context of the moment and the expectations for behavior, dress, and functioning. I found myself saddened today. We came home and got the mail that was held during the week between coming from Florida to here. And I opened up one of my dress catalogs to think about ordering and saw a couple of dresses I absolutely loved, and then realized I couldn't justify because I don't know the next time I will be in a public place to wear a dress. And I don't know I want to wear a dress around the house, especially as I adjust from 80 and 90 degree weather to 40 and 50 degree weather in New York. Think about how everything has changed for people with dementia. If they were going out into activities, is their dress changing? Does it need to? And if it is, can it be in ways that will be comforting for the person? Maybe looking at, are there soft materials they could wear that are warm materials while they can't go out, things that they wouldn't ordinarily wear. Or do we want people to dress up to give cues? For example, if you're doing the movement activities of dance at the same time, there may be tights and outfits, exercise outfits people wear that may be an important cue of what's expected for people. The concept of time for most of us is based on the day of the week, our activities and everyday activities, but when 7 days all look alike, it becomes difficult for people to function. It is also based on the season and weather related, and so, you know, people not going outside and feeling the temperature. We need to think about other ways people can be outside, still not extremely close to people, but ways to be outside. The worksheet that I've given you is a worksheet which has the normal routine and these questions on, and you're welcome to go in and look at them. What is the normal routine for weekdays for the person? What is the normal routine for weekends? What's changed? Specifically, how have routines changed? Sorry, I see a typo there. What inappropriate behaviors are you observing? What was the function of the routines and how can you replicate or replace? What function of the behaviors that you're seeing? And what can we do to help bring back habits and routines that will be appropriate and may help minimize some of the behaviors, quote unquote, that you're seeing? And what changes have you made you want to carry over to our new normalcy, our new imagining? And so I really want to try to keep this positive in what changes that we have to make, that we have no choice about making, can be positive, that we can continue to carry over into the life as it comes to us. With dementia, anyway, people are in a different time and place. Do the objects you're using around support that time? If people were used to 1950s and 60s, 70s telephones, and now all the telephones that are around are cell phones, iPads, there may be people with dementia who can't use them. Do you have the older objects available so you can have those that people can continue to use those older objects? Do we expect too much from someone to be able to use objects that are not familiar to them in recent time? And if we can replace with some objects from the longer time, the longer memory, what a difference we can make. What are the challenges in the environment, the new routine? What do I choose? Look at this. This is a mass of choices. How do I use these objects? What choices do I have other than to run away, refuse to eat? Are these choices different every day in the new pattern of each day? Is my cognitive loss showing? And I'm asking these questions from the point of view of a person with dementia. How can I pretend I'm okay, or do I want to pretend at all? How do objects like toilets, sinks look different? Are they different at the residence than they were at the day program? And are they different from room to room, from bathroom to bathroom? And so looking at objects, seeing areas where people may be having difficulty, and thinking about how you can help. And the fact all of these are white without good contrasting color also makes it difficult. How many times have you heard about someone complaining that someone, a male, went to bathroom in a sink? And how much does a sink look like is here? You know, think about the objects. What do they look like? Were they part of the previous routine? What do we need to do to help make that look normal, look like something a person can use? This is just a small sample of how different faucets can look. And are the faucets in the day program, the activity areas, different than the residents? And thinking about even after this time, can we try to have the faucets in the program look similar to and be more practical for use at the day programs and the activity areas as we do in the residence. Let's talk about sensory processing, IDD, and dementia. Sensory processing is the ability to use all 8 of our senses together. And the 8 senses: vision, auditory or hearing, tactile or touch, smell and taste I've put together, though they are separate senses, but they work so closely together. Vestibular, which is balance, and anytime our head moves through space. And proprioceptor, location in space. And interoception, the inner sense of our organs, a sense of hunger, thirst, hot and cold. And so these are the 8 senses. All of these with aging may be impaired. And now we add on further brain damage because of Alzheimer's disease or related dementia. And now we find that there's increasingly problems of bringing the sensory information and the environment together to make it understandable and to be able to use to interact with our physical environment. Sensory processing occurs in the brain and the central nervous system. The brain automatically receives sensory information and pays attention to the meaningful information. What is meaningful to the brain? What's meaningful to the person based on long-term memory? It's not usually the short-term memory. It's the long-term memory of what's meaningful in the environment. Ordinarily, the brain filters out information not needed, and ordinarily there's an automatic and subconscious action. It allows us to interact with physical and social environments and can be interrupted by lack of habits and routines, which is what's happening now. Diseases can cause disruption. And there may be, for people, sensory processing is something that is only recently being diagnosed in children, and usually children on autism spectrum disorder. That's why most of the resources you'll find in this, and one of the major resources I've used over the past couple of years, The Out of Sync Child by Carol Stock Kranowitz, an excellent resource in terms of explaining sensory processing and how it can be dysfunctional. There are very, very few resources for adults, and certainly very few on sensory processing for adults with ID and dementia. There are some for adults with autism. Most of that's where the research is. And for the environment to feel safe and comfortable, there needs to be the ability to bring together the sensory information. And without consistent routine, it's like pulling the rug out of sensory processing possibilities. Here are some signs of sensory processing. And again, this has mostly been diagnosed in younger children or young adults. There are very few middle-aged and older adults, especially with ID, who have ever been diagnosed with sensory processing. But I'm sure there are many, and the predictions are that there are many that have been blamed or given labels on mental health or other underlying problems rather than it being a sensory processing disorder. For example, someone who covers their ears when there are loud sounds such as vacuums, hair dryers, may even scream or cry in a reaction. And we see adults who do this. But we think of them often, unfortunately, as inappropriate behaviors when it can be such pain from the sensory processing dysfunction that it makes it impossible to function. May have issues with food textures. Gagging is common when trying new things, new foods. Can't be touched or can't be touched enough. And we'll talk about tactile defensiveness in a few minutes. May show little or no reaction to stimulation, even pain or extreme hot and cold, or overreaction to pain or hot and cold. Now, if someone is older and has a diagnosis of Alzheimer's disease, these will often be blamed on Alzheimer's and may be looked at how we can just eliminate rather than thinking about what is being communicated with this behavior and what can we do. These are painful experiences. How can we reduce the pain? May have poor coordination, may be an excessive risk taker, crashing into things. And this, of course, during this time when we may be isolated in residence with a number of people, maybe even more difficult of someone who's bumping into things, crashing into things. May cry out or get upset over clothing tags or textures. May be sensitive to light. May dislike hair being cut or brushed. Being cut in these times is certainly not as much of an issue for most of us. Here are the 7 senses and sensory integration. Auditory, visual, taste, tactile, smell, vestibular, and proprioceptor. I'm going to talk about those. Every one of those work together to help each individual function and respond appropriately in the context of the environment. We need to be able to discriminate, modulate, and integrate the senses. These are all steps of sensory processing that requires a healthy brain. A brain that has disease process will cause dysfunction and interruption in the process of being able to discriminate, modulate, and integrate the senses. And it's also a likelihood of preferred senses. In studies for people with Alzheimer's disease, there seems to be a consistent, in many, many studies, recognition that visual is the most relied upon sense for people with dementia. And that's very similar for people with autism, by the way. Studies also are conducted on proprioceptor and vestibular system and find that lack of location in space and time, orientation to self, knowing who they are, where they are, seems to be one of the #1 challenges for people with Alzheimer's disease. People are meaning deaf. They may hear words, they may hear communication and sounds, but those sounds no longer have meaning. Meaning blind, and so objects not having the same meaning that they had younger in life and before the disease process, or may never have the meaning that others thought they may have. A need for structure and routine. Over and over, this is essential for people with dementia, and for all of us, it's essential. It becomes even more so within this disease process. So let's talk about sensory impairments. Visual impairments become much more common as we grow older. And with the disease of Alzheimer's disease, there is further brain damage going on. It is likely those impairments that are age-related are likely to increase as people grow older and have this disease. And so it's likely to hurry it up. So think about someone who's now either in a new environment or with new people. They have dementia, routine has changed, so they can't rely on the routine to get around their environment as much. And they may have central visual impairment, which is caused by cataracts and stroke, are the 2 common causes. And you can see in the lower right corner, that is a central vision defect. That's how people's faces, people may look to someone who has cataracts or has had a stroke. Peripheral visual impairment, glaucoma, retinitis pigmentosus, very, very common causes of peripheral visual impairment. And on the top right, you can see there's normal vision, and then you see to the right-hand side vision with glaucoma. The whole field of vision has narrowed. You can bet on it that there are people with dementia who have visual impairments. That increases as we get older anyway, and now add another part of the brain damage on, and it's increasingly likely. Auditory impairments. So this conductive hearing loss is caused by damage or destruction to the outer or middle ear, prevents transfer of the sounds in the environment to the inner ear. Sometimes it's temporary, and sometimes it's permanent. Then there's sensory neural hearing loss caused by damage to the inner ear or the auditory nerve. And if you can look at age 0 to 17, now this is for people, the general population, all people 0 to 17, approximately 5% of people or children, very young children, 0 to 17 have 5% hearing loss. Now for people with Down syndrome, that's much higher percentage than the 5%. By the age of 18 to 44, we're looking at 23%. Some of the studies we've seen for people with Down syndrome, we're seeing about 40%, 40 to 50% by the age of 40 for people with Down syndrome. And so there's that earlier aging into the risk of impairments and loss. By the age of 45 to 64, approximately 29%. By the age of 65, 43%. And we know by the age of 75, most studies conclude 1 in 2.5 persons has significant hearing impairment that will get in the way of communication. So now add on disease process of Alzheimer's disease, and not only is there the hearing impairment, now we add on the cognitive capacity for the brain to take the sensory information in and to interpret what that information is. And so there's increasing likelihood that verbal communication is confusing and is difficult to understand, especially if we're using different language than we were, especially if we're using language around COVID-19 that may be it was unfamiliar language to us 2 months ago, and has now become common language. There is also a correlation with the higher there's a higher incidence of a diagnosis of Alzheimer's disease for people with hearing loss. And so there's that correlation. People can also be meaning deaf even though they may not have significant hearing loss. Hearing loss can appear as a type of dementia, so we want to be careful that we're not confusing and diagnosing people or assuming dementia in people, especially people with Down syndrome, because especially during this time, seeing people who are hearing things differently, that may be responding differently within all the anxiety and the changes in the environments. I love this. I think you need a hearing test. And the response, why the heck do I need a hairy chest? We think that maybe this person is getting Alzheimer's disease when he couldn't hear. And sensory overload, which can be extremely painful and cause what we think are inappropriate reactions, inappropriate behaviors. Smell, taste, and the environment, there are differing degrees of sensitivity, age-associated changes. There may be too much or too little smells in the environment. The smell and taste go together, and there has been recent discussion the loss of smell and taste may be one of the symptoms for the onset of COVID-19 or being COVID-19 positive. However, there are many age-related and age-associated conditions that can also have smell and taste loss that can be a symptom for it. It can be the underlying cause for refusing to eat or inappropriate behaviors. And in the residential environments, the more cooking we can do, baking, the more we can put pleasant smells into the environment, smells that can stimulate routines and habits and activity and stimulate appetite, the better off people will be. And of course, medications change taste and smell as well. Tactile sense in the environment. There are those who study it who feel that it's the first sense developed and last lost. However, I've also seen those that study that say that the auditory. And there is some sense that infant or children, fetuses, developed fetuses can literally smell their mother. There is also some sense that vibrations of sound seem to get to the developing infant. So We're not sure, but it is likely that this sense is one of the very first after the infant is born. There are different degrees of sensitivity. Environments can have too much tactile information or not enough to meet person's needs. And the one thing we know for sure is those environments have changed. And we may need to add in tactile information or take out tactile information. Especially for clothing, looking at the clothing, looking at making sure that we're helping locate people in space. We may need blankets or heavier clothing to help people, especially with dementia. Tactile sense is probably one of the most unrecognized senses for causes for many behaviors. Tactile defensiveness, which is the inability to interpret appropriately the effective meaning of touch within the context of the situation. Maybe a disorder of modulation or a regulation of tactile sensory input. It can be a sensory processing impairment, dysfunction. It can be a sensory impairment related to touch. People who avoid touch and hugs. These are actually people who probably are having a little easier time of not being touched and not being hugged right now because of the whole social distancing need and the contagion factor. Avoidance of textures, preference for certain clothing, refusing to wear anything else, and that's okay. Also always think about it, what does it matter? Does it really matter what people wear? It certainly matters that it's warm, that it's safe, it's comfortable. And so, especially during the time with people at home, thinking about what will help people feel safe and comfortable. Avoidance of baths, daily living tasks, hair care. Avoidance of dental care. Again, probably something, unless it's an emergency, people are not receiving dental care right now. Responding by withdrawal or aggression to light touch. Increased stress when close to people. Now, in residences where there may be 5, 6 or more people, and then also 2 to 3 caregivers, the amount of space may be very limited, and this certainly during this time can be adding a great deal of stress for people who are tactile defensive, pulling away or aggression to light touch. And for people who are lost in space, who don't know where they're located in space, tactile defensiveness is likely going to be even worse, because if you can't locate in space, you don't have a sense of how far people are from you. The concept of 6 feet will mean nothing, especially if you're tactile defensive, and especially if you are not located in space. People who rock, who are easily distracted, increased levels of activity, of poor tactile discrimination, does it increase or decrease with age? Here's an example of tactile defensiveness. It may look harmless to you, but especially frightening to the person with dementia. So putting the sock on, you may think is harmless, but for the person it may be as though that alligator, having just left our house where we have a pond where there actually has been an 8-foot alligator there on many days, and walking right by our house a few times. This particular visual for me puts it in real perspective. Alternatives to handshakes, hugs, high fives. Here are some examples: the wave, hand on heart, namaste, how are you? So here are some ways for options for hugs for people who may be used to hugging that we want to substitute for people. Movement in the environment. To be able to move freely throughout our environment is often taken for granted. We use all our senses to move throughout our environment. If any one of them is faulty, and then we have brain damage on top of it, it is likely mobility will be affected. And for all of us, the right to move throughout our environment is a basic human right, we hope. Vestibular system works closely with the proprioceptor system. Whenever the head moves through space, you are using the vestibular system, and this works closely with the proprioceptor system. Movement can often be therapeutic and even necessary for functioning. In our residences, we need to make sure that people have the opportunity for movement. We need to find ways for people to move, because it will especially be therapeutic in these high anxiety producing times. Proprioceptor system gives us a sense of where we are in space, and as part of motor planning allows us to sequence and time activities. And so things like touch and hugs when appropriate, which we can't do right now, is usually what's recommended. But we can substitute weighted vests and blankets, as long as they're not too weighted, especially for someone who's very frail and arthritic. And so we always think about what are the underlying conditions and how can we help that person be located in space. Some dysfunction people who seek out jumping, bumping, and crashing activities, bite or suck on fingers, frequently cracks his or her knuckles, loves to be tightly wrapped in many or weighted blankets, especially at bedtime. And again, we have to think of whose issue is it, grinds his or her teeth throughout the day, chews on pens, straws, shirt sleeves, etc. And so these are some signs of people having difficulty. We need to find other safe ways to help people function. These are examples of lost in space and time. Where are we? Who are we? How do we find our way to safety? And I'm sure some of us feel this way during the COVID-19. This is actually an example, and I've seen one very similar. I had a staff very, very proud to have developed what has often been called a snooze-a-loon room, which is supposed to be for sensory. We need to be very careful that we don't overstimulate, that we don't develop sensory areas that are overwhelming for people, especially during this time of anxiety. One or two of the sensory stimulation may be appropriate, but not all of it together all at once. So redesigning our environments, and I hope that's something that will come out of COVID-19, of thinking about how can we change the physical environments. Let's reinterpret social distancing as an opportunity for development of territory and personal space. This is something in our organizations, in group settings, we've always had a difficult time with, giving people personal space, which is the immediate space surrounding a person, the territory that refers to the area which a person may lay claim to and defend against others. This was an exercise to give, for instructors to give, introduce the concept of personal space. Sit or stand in a place that is unusually close to one of your students without touching the student. After a minute of sitting or standing there while the class wonders what you're doing, ask the student how she or he feels about your location. Think about yourself. How close do you like to be to people? And look around you. Each of you has established territory. It may be your computer, there may be personal objects surrounding you. You have created a personal space and a territory. And the territory is the material space and objects we claim as our own. Think about what objects are important to people with dementia. How can you help create a personal space, a private area, an area where there are material objects that people can have around them to help them feel safe, especially during this time of COVID-19 and the change of routine. But think about how can you carry this over to make the environments less stressful, less overwhelming, and ways that we continue for people to have quiet, personal space and territory, and ways that people can continue activities in spaces that are not other people's spaces, to give a sense of that personal space. There are ways of defining personal space. Intimate space is space very close, maybe touching. Personal space a little bit further out. Social space 1.2 to 3 feet by many studies. That's far less than the social distancing we expect. And then public space 3 feet plus, which is really what we're asking for with social distancing. Depending on the relationship, the culture and personal preferences will make a difference of how personal space and intimate space is defined. And thinking about how we can give people a sense of this giving social space and public space a wider berth of that being personal space for people within our residences. Also proprioception and movement, opportunities to touch textures and objects, controlled spaces with lots of cueing, clearly identifying beginnings and endings of space for people. Think about how you can do that through chairs, through furniture, through contrasting color, through personal objects around a person. There are ways that you can do this. This is actually, those of you who've been in the training know that this is one that Catherine stole from me, and is one that is hiding.
Oh, Kathy, that's my picture.
I know, no, it's not. Well, in this case, it's mine tonight. Back to mine.
I couldn't resist.
I know.
I'll mute myself again.
No, you're fine. You're fine. This was an elevator out in Phoenix, Arizona that we had. One of the organizers, her husband was a professional photographer, and he took that for me at my request. But as I said, Catherine, our training has taken it over. But this was purposely to define an elevator and to make sure that people with dementia were not wandering onto the elevator without being escorted. You can do this in the personal environments. You can hide places that are dangerous, but you can also make an environment feel restful by how you decorate it around. And there are some simple ways you can do that. Some environmental supports in the residence, visual schedules, visual supports, finding things that are meaningful for people with dementia, and as much as possible, finding ways that you can use those visual supports to help the people be located in space and what is expected of them. On the right, you can see actually the schedule for brushing teeth, and then being able to actually move this over into the finish column. Study after study has shown that for people with autism, and we found this also very typical for people with Alzheimer's disease, that saying good job or you finish is not a reward. What is more a reward is visually to see that the task has been accomplished. And so by being able to move that over, it says that activity is finished for this time. And so you see each of these having a visual activity, and then helping the person, once the individual has completed a specific task or activity, to move it over into the finish column. And so thinking about ways that you can help show people visually that the skill has been completed, the particular task has been completed. Here are some examples. These are actually all inside a nursing home in Germany. This is not outside. They have created a mural behind and put a park bench for people to sit on, so they feel they're sitting there, and doesn't matter, they think that it's the bus they're waiting for, if it's something that feels good to be interacting. Now, obviously, this was done before people were supposed to be socially distanced, but there could be ways that there could be dividers, so people can't sit right on top of each other. That could be a bench, and there could be another type, could be a park mural behind for people to sit and look at and have a separate seating. This idea of this, again, is inside an area to make it look like it's a post office. And again, a bench here to look like they're waiting for people who may be wondering why the van isn't coming or mom isn't coming to pick them up. Thinking about, are there visual things that can ease people or distract people? Outside sitting area inside, isn't this a way to make mealtime if you had the space? And you might be able to do this in program areas so it looked much more pleasant and you can have people further apart. And this is something, as we slowly move back into people going to programs, we're not likely to have as many people for quite a while in the same room together. And so we're going to have to create smaller places for fewer people. And maybe doing this in the residence. Do we really always want to eat with 10 people at a time? And might it make sense to break areas when you have enough space up for people to sit quietly, to do activities or to have a snack and a meal time? And this may be the time we can break snacks up to many during the day instead of huge meals, which often people with dementia can't eat and often get hungry in between but can't communicate that. I know many of you have already gone to virtual activities and technology. Create quiet and individual private spaces so that people can have individual interactions with family, clinicians, peers that they usually would spend time during the day. People, especially with dementia, don't understand why they are separated from others, why people aren't visiting. And so trying to virtually replace that is something that can be done. Now, I would prefer, it's very difficult to find good examples, but here's a way you could separate by doing the same things we do. Sorry, I moved that. In hospital settings, but in rooms with having this room divider, but having different colors to identify and different cues of this is an area and giving personal space. The best way to take yourself from the environment to figure out how to change the physical environment to support people with personal space and territory is to take a photo. That will take you away from the environment and give you ways that you can do simple changes for people. See the environment from a different perspective and do it together with a person. Have the individual as much as possible help make the changes. Know their favorite colors, favorite objects, and put them around. And it is not time to worry about, are they too attached to a doll or a teddy bear? This is the time people need supportive, comforting objects around them. Reuse some of the space used for programs in different ways, and think about maybe in the future how you're going to do that, because it is likely we're going to be going to smaller programs, smaller activity, in fewer people together in the same space, especially until there's a vaccine that becomes available. Zoom, Skype, and web radio to promote social contact and face-to-face support as much as possible. Apps and online videos, counseling, chair exercises, yoga, keeping fit, cognitive stimulation and information. Develop walking paths and ways for people to walk around the residence outside as the weather gets better. Facilitate contact with relatives and close friends of the person with dementia via phone and online communication, FaceTime. It is not easy, but it is possible to visualize a new world that together we can figure out how to make a difference. Questions and comments. Let me, before we go to questions and comments, let me pull up the two other tools that I have for you. This first one, can you see this?
Yes.
Okay. Here is a tool that I've developed. As I said, it's very rough. I hope to work on it further, and my formatting person is usually Catherine or other people, so may want to take and may want to add behaviors and other sensory things into this. But this is something you're more than welcome to use. Please let me know if it's helpful at all. If it's not helpful, let me know that. I won't spend time working on further, but this is something I wanted to leave for you. The second material that I have is environmental sensory processing awareness checklist for residential programs. This is something I developed when I was at the University of Rochester School of Medicine and School of Medicine and Dentistry. Both of these are available. You're welcome to share them with anyone. You're welcome to use them. And I do have 2 others of this. I have one for individuals, a sensory and processing awareness checklist, and I do have one for programs as well. So please do use these. Please share them. The only thing I ask is that you credit them to me. And I welcome any questions, anyone. This is quite extensive and quite lengthy. Years ago, it was about 2000, actually, it was 1999. I had been doing this for years, and I had a number of people said, please, will you put this on paper, how you do a residential assessment? And so this is the result, these 3 pieces. I hope they're useful for you. Let me know if they are. I'd like to do some modifications specifically for people with dementia. So if it is helpful, just let me know. And so please help ask at any time. Go ahead.
No, we have one comment from Melissa Kushner. Oops, another one coming in. Let me back up here.
Okay.
From Melissa saying, these are great. Do you mind if we share these tools? And I think you just answered that. As long as
Yep.
they do it with proper attribution, that's fine. Deborah Seaman, will you please share the program and other tool as well with us?
Yeah, that's what the materials are. So
yeah, you've got that. Yeah, you
yeah.
And it'll be included in your follow-up email as well.
Sure. But please, and if you have any difficulty getting them, please don't hesitate to contact me. Here's my email. More than happy. And if you have questions specific to your program, something Catherine and I have been working on for some time and hope to over the summer be able to do this, is for the trainers to have a 4-part series on going into more detail of connecting behavior to sensory and physical environment and ways to modify and change. So in fact, we will be doing 4-part session with some Nebraska as a result of a small grant with Nebraska starting next week as well. So please do ask for any help that we can provide.
And we have another comment, Kathy, from Kristen Rains, who says she's tried doing Zoom calls with her Alzheimer's clients, but the technology was too unfamiliar with them, unfamiliar with them for them to be able to engage. And I assume, Kristen, by that you, I'm not 100% certain. Obviously, they would need someone to set it up and to place the call and so forth with them. I don't know if you mean they were confused by the image of someone talking to them. If you're still there and can maybe give us a little bit more detail, or we could even unmute you, I suppose, Kathy.
Sure. If you could unmute Kristen and have her explain a little bit.
Yeah, let me do that. And also, I've got, before I do that, we have Kara Akuri, who says that they're using iPads with residents, and many are already familiar with that, which may help. And I think, a lot of people with Down syndrome pre-dementia have been using iPads. And so that, might be a more familiar technology for them. Let me get to Kristen here. Kristen, and hang on just a minute. I'm scrolling up here to find you, Kristen. And bear with me. Got a lot of names to get through. Here we go. Okay, Kristen, you are self-muted. Do you want to unmute yourself? Can you unmute yourself, Kristen? Kristen.
Hi, am I unmuted?
There you are. Hi.
Sorry.
You are, yeah.
I mean,
Great.
you basically covered this. I think the technology was just so far beyond them. This was older clients, right, who were more familiar with a rotary phone. She just kept looking off to the side and say, "What is this? And why do they know my name?" And it was impossible. It was really hard to engage them. So
Yeah,
it was sad. I tried.
Yeah, but for some people, you're exactly right. And these are only suggestions. They don't work for everyone. And for some people, that vision, we might call it hallucination or paranoia. With people who see that because they're frightened and they can't cognitively understand. And you're right, it's because they're older, long-term memory. This particular piece of technology, they have no reference to. And so with some people it will work, with some people it may not be soothing at all. Then there might be ability to do a video that could be the family member or the clinical staff. And that could be shown on the TV, which might be more familiar. And so the technology is really based on what works for each person. You're exactly right, Kristen.
Yeah, Kristen, let me just add a couple of things. One is, I guess I'm not totally surprised, because if you think about, you know, FaceTime, Skype, Zoom, all of those sorts of things, it requires you see an image and you have to, in your brain, put that together with the fact that there's a person on the other end you're talking to and where their voice is coming from. So it's pretty really complicated when you stop to think about it. But to Kathy's point about the video, there was some research done a number of years ago. I'd have to go back and find the study. I probably could if I tried hard enough. But it was a study of people in the general population with Alzheimer's, but they used videos of their family members talking to them. So it didn't require the person to interact with them and have a conversation. It was just a video of the family member talking to them. And as I recall, it had, you know, some promising results. So that could be maybe an option if you could get family members. Of course, it's easy to kind of do with your phone now. And that might be easier than having to have that back and forth conversation on a Skype or a Zoom. I don't know, just my 2 cents.
That's a good idea. I'll try that. Thanks.
I'm sorry. Go ahead.
Oh, I just wanted to say that's a good idea. I might try that rather than trying to actually have a conversation.
Yeah, and it might be you need a photo album for some people, and they sit and look at photos. And you know, and so it won't work with some people, but many people it will.
And we have another comment, Kathy Service here. Hi, Kathy. Says the OTR who works with Dr. Chacoin. Actually, she was on a webinar with him today that I listened in on. I think her name is Dr. Frank, but has some incredible strategies to work on sensory issues with people with Down syndrome of all ages. They gave a great webinar recently and reviewed sensory issues in relation to behaviors, very practical too. And they have the Adult Down Syndrome Center, I guess it's called, in Illinois, Dr. Brian Chacoin. They have a great website with a lot of resources and videos on their website. I'll try to think to maybe include that in the follow-up email, because they've got a lot of great resources.
Yeah,
David
I would
Schumacher
love to see
says,
the link to that as well. And for those, Kathy Service will be doing next week's webinar, who will be talking about ways to stay healthy during COVID-19. And so we're also looking forward to that. And thanks, Kath.
David Schumacher says, we mirror the Zoom, FaceTime, etc. onto the TV, a smart TV. Many times the TV is more familiar and the family member is now larger and up close. Oh, that's a good thought.
Yep, yeah. And sometimes just doing an audio of a voice, or an audio of a family member or friend singing a song that they're familiar with. And so it's very individual, but thinking for this person, what can we do that can help support that person who's not able to physically be with those that are comforting to them.
Yeah, I like the idea of you know, putting it through onto a larger TV screen or whatever. I think, you know, it could be that the small size screen from either an iPad or a phone or even a computer screen might make it more difficult for the person to understand what it is. So I think that's a great idea.
Yes, perfect.
That's it with the questions, and we are literally right at 2 minutes before 7:30. Kathy, do you have a story or anything you want to leave us with?
No, well, I'm not going to leave a story today.
Oh my gosh.
Well, do you want me to do the eagle one? since I have an eagle in front of me.
You do whatever it is you'd like to do. The last 2 minutes are all yours.
Okay, well, actually, let me do an eagle-related one. This is one I haven't told in a long time. Literally, in our travels, my husband and I would collect Native American traditions, art pottery, basketry, and especially we love learning the stories, the legends, and the traditions. And this is one my husband found, and it is about an eagle's. I'm sorry. Yeah, an eagle's egg that rolled down and somehow fell into a prairie chicken's nest. And the prairie chicken mother continued to, and the family, lay on the eggs until they hatched. So they hatched one eagle and the prairie chickens. And the mother, this is a tradition, whether it can happen or not, I don't know, but the mother continued to take care of the little eagle as well as the little prairie chickens as well. And so one day the little eagle is standing alongside the prairie chicken, looked overhead and saw this beautiful creature, very similar to the photo I have here, soaring and swooping overhead in the most beautiful free movements this eagle had ever seen, this little eagle. And the prairie chicken sibling standing next to her said, why are you looking at that? That's an eagle. We're prairie chickens and we're scratching in the dirt and we're looking for food to eat, and this is what you need to do. And so the prairie chicken / eagle, listening to the sibling and believing, at least for that moment, that this is what the eagle / prairie chicken should be doing, continued to scratch in the dirt, and the beautiful creature soared off in the distance. And the eagle / prairie chicken never saw this creature again. We all have wisdom of eagle. We all have wisdom of possibilities. And so please, please think about the possibilities of supporting. I hope that I've added just a tiny bit to your already existing wisdom and your compassion to help you make a difference for others. And please don't ever, ever hesitate to ask Catherine, myself, or Kathy's service and others on this call with the NTG for any way that we can help you through, especially COVID-19, but also through the time of supporting people with dementia and ID. Thank you, and each one of you, please stay safe and stay healthy and well.
And we'll see you next week when Kathy's service comes on to talk about infection control. So stay safe, everybody. Mahalo, Pokey, and thanks, Melissa. And we look forward to seeing everybody next week for our final webinar in the series. Thanks, everybody. Good night.
Rick, real quickly, I have already scheduled the next 5 after this, so that will be an attachment for next week for us.
We'll get that information out to everyone. Good night, everybody.
Good night.